Our next keynote speaker and the final speaker of today has been a GP for 28 years. He has some quite impressive CV, but I'm only going to mention that he currently serves in London, and he's the Professor of Healthcare Improvement at University College London. And he is going to talk about change, I believe. Please welcome Dr. Martin Marshall.
Thank you very much indeed. This is a day of firsts for me. It's the first time I've had the privilege of speaking at a Nordic Congress, and that's wonderful. It's the first time I've ever been to Iceland, which is just brilliant. And it's also the first time I've ever given a presentation from the middle of a flower bed. But I have taken antihistamine, so I think it's going to go okay. I guess all of us as GPs sometimes have consultations that don't start very well, that don't finish very well, and the middle isn't very good either. These are the consultations where the patient goes out of the door shuts, you sit back in your chair and say, what the hell was going on there? I had one of those consultations recently with a patient of mine who I'm going to call Laura. Laura's in her early 20s. She has mental health problems, serious depression, and a lot of attempts, suicide attempts, mostly overdosing on her antidepressants. For the last year or so, Laura's been doing really well. I've been seeing her monthly just to keep a check on her and to give her her monthly prescription of antidepressants. But a short while ago, she said to me, Dr. Marshall, it's really nice to come and have a chat with you, but it's a bit of an inconvenience having to come once a month. Could you give me my prescription for 3 months instead? And I said probably what most of us would say in this audience. I'd say, I understand, I'm sorry it's inconvenient, but I'm a little bit worried about you taking an overdose again if your mood drops. And her response was really interesting. She said, I realize that's why you do it, but it doesn't really make any difference to me. And she describes how she got together with her friends. Her friends are here in this photograph as well. Many of them are also registered with me. They also have depression. She says, we sit down together, we have a few drinks, we put all our medication in a pile in the middle of the table, and we draw straws to see who's going to take the overdose. Now, sometimes our job, I guess, what did I feel like doing? I felt like saying, why? Or a slightly more fatherly, why the hell would you do something as stupid as that? But I managed to restrain myself because sometimes our job as GPs is simply just to understand the human condition, however irrational and inexplicable it sometimes is. I've been a GP for nearly 30 years, and I've seen quite a few people like Laura over that 30 years. Indeed, I don't think things have changed very much. But here's the paradox, because as the essentials of human existence don't change very much, society has changed really dramatically over that 30-year period. In Future Shock, Alvin Toffler, an American futurologist, said that novelty, transience, diversity, and acceleration are what modern society is all about. We travel more and faster. We relocate more frequently to new residences, which are built and torn down more quickly. We contact more people and have shorter relationships with them. We're faced with an array of choices amongst styles and products which were unheard of the previous year and may be obsolete or forgotten by the next. And Toffler said this in 1970. Before the internet, way before the internet, before change really took off at a fast pace. Toffler died at a good age earlier this year, but I wish he was still alive because I'd love to invite him into one of my surgeries. And I suspect that if he looked at one of my surgeries and compared it with what it was like 30 years ago, he'd probably describe some dramatic changes in the clinical care that I provide. How I rarely see heart attacks anymore, how I rarely see acute asthmatic attacks, how I see more long-term conditions, more multimorbidity, how I have more effective treatment for conditions like depression, how I do more prevention, how I can target care more effectively, and I have new treatments like triple therapy for Helicobacter pylori infection, which have made old treatments like surgery for gastric ulcers completely obsolete. But he'd probably not just describe changes in what I do, but he'd probably also describe changes in how I do it as well. How I communicate differently with patients. I use the phone more, I use email more, I do online consultations, Skype consultations. How I work as a member of a multidisciplinary team surrounded by lots of different professionals, non-doctor professionals. And how what I do is more scrutinized, more managed than it might have been in the past. So whilst the essence of the consultation in general practice hasn't changed, general practice looks different, very different from how it was, and it continues to change very rapidly. In this presentation, I'm going to describe 3 presentations which I see in general practice around me at the moment. These are changes which aren't necessarily the most obvious ones if you look at general practice, but they are the ones which I think have the greatest implications for the future of our specialty, for what we do as GPs and for what we hold as important. The first of these is an increase in the scale of general practice organizations. The second one, which we've been discussing with Gilbert, is around the challenges to the medical model. And I can't add to what Gilbert's described. He's a beautiful description, erudite description of over-medication. But I do want to add a kind of GP perspective to what he's described. And then the third change is a greater focus on the social determinants of health. So I'm going to explore each of these changes and their implications for general practice. But first, I'm going to quietly answer a question which some of you might be asking, at least because I know you're very good mannered, at least under your breath. Why on earth should we be interested in what's happening in the UK at the moment? Like Gilbert, I'm very proud of my country, the United Kingdom, although it does seem to be fragmenting rather into its 4 different components. I've got a New Zealand friend who's got mild dyslexia, and she calls the United Kingdom the untied kingdom. She says it isn't a joke. And of course, we're walking away from Europe at a time when it seems to be Europe is far more important than it's ever been. So we're increasingly isolationist as a country. I'm not particularly proud that the UK a year ago, when we voted for Brexit, was the first country to kind of start breaking up the world order, the established order as we knew it. And it seems to me it's more important than ever that the Nordic countries, Nordic heaven as liberals like I tend to call it to the United States, are seen to be in the lead in terms of the values that are so important to us in society and to us in healthcare as well. Nordic countries should be acting as a beacon to the rest of the world. So the UK isn't a great place to be at the moment, but that doesn't mean there isn't some really interesting stuff happening in it. We have a national trait as British, which we're never satisfied. We're constantly questioning. Even when we have something good, we try to change it. That's why we have this reputation for creativity in the arts, in music, in high-tech industries, and also in innovation in healthcare. Somebody once described the UK as an offshore laboratory for crazy health policy experiments. I think that's probably about right. If you look at what some policymakers do to both health professionals and to patients, if it were a research study, it would require ethics approval. They don't get it, I should say. So if I'm generous, I think the constant experimentation that goes on in the UK is a reflection of our love affair with the NHS. In 2012, we hosted the Olympic Games in London. This is a wonderful opportunity for a country to showcase what's important to it. So what did we do in our opening ceremony? We celebrated our agricultural past, we celebrated democracy, we celebrated the Industrial Revolution, we celebrated pop music, the internet, the monarchy, of course, James Bond, and we celebrated the NHS. I remember an American colleague said, "You celebrate your health service? What a weird thing to do." One of our politicians once described the National Health Service as the closest thing the British have to a religion, and I don't think he meant that as a compliment at the time. So we're always trying to find solutions to what are essentially insoluble problems in our health systems. The same for all of our health systems. How do you improve the quality of the care you provide whilst controlling the rising costs? So here's 3 possible answers, 3 possible changes that I see happening in the UK, which I think are potentially very important to the future of general practice. The first one is the increase in scale of GP organisations. And I want to present that, if you like, as a hypothesis. My hypothesis is that general practice may be more able to do a better and a more sustainable job for patients, for the communities we serve, and indeed for the whole health systems, if it operated at a larger scale. The traditional model of general practice in the UK is very similar to other European countries. We're based around small, relatively independent general practices, perhaps 3 or 4 GPs, practice nurses, managers, administrative staff, serving a population of somewhere between 7,000 and 9,000 patients. This has increased over time, but the model now is very similar to the model that you might have seen 30 or 40 years ago. This is a model that served the United Kingdom extremely well. The Commonwealth Fund of New York, an independent foundation, produces regular summaries and rankings of health systems in different countries. And the UK consistently, over the last 5 or more years, has come out in the top 3. And it's widely recognised that one of the reasons for that is the strength of our system of general practice. But despite that, there's a growing argument in the UK that the current model of general practice isn't fit for purpose, that it doesn't address the problems that many people are seeing, that it's not big enough. And that argument comes from both policymakers and indeed sometimes from the profession itself. The argument from policymakers, the particular enthusiasts for larger scale general practice, is that in order to address a number of key issues in general practice, we need to be bigger. We need a larger size in order to provide greater skill mix, to make better use of the primary care workforce. We need a greater size in order to be able to provide a more population perspective in addition to the one-to-one individual perspective that we provide. And that we need to be bigger in order to have a greater influence on the wider healthcare system. The argument from GPs is possibly less positive. They say, well, we'd rather keep the size of practices that we have now, but basically they're not sustainable anymore. The economic model doesn't allow small organizations to keep going. And they also say the only way that we can respond to the constant government demands, particularly around regulation, is to be larger organizations. Whatever the arguments, what we're seeing is the emergence of a range of different larger scale models of general practice. And I want to describe 6 different models that we're seeing emerging in the United Kingdom at quite a rapid pace at the moment. The first one is simply practice merger, where 2 or 3 adjacent practices come together as a single organization, but essentially carry on operating as they would have done as a smaller organization. The second model is a model of cooperatives, where adjacent practices in a locality, perhaps serving a population of 150, 200,000 patients, work together on a range of different issues. They maintain their individual identity, but they share some resources, they share some data, they do things like quality improvement work together. The third model is the so-called super practice model. This is a model where practices come together with multiple property-owning, business-owning partners, and they share all of their resources, particularly their back office functions. And there's an example of this in the middle of the country, in the Midlands, close to Birmingham, called Modality, which currently has 35 different practices, 140 different partners, and operates in a really interesting model. The fourth model is a so-called corporate model of general practice. This is a model where a relatively small number of doctors, perhaps 3 or 4, run a much larger organization and employ their GPs as salaried employees within the organization. So this is a model like the Hurley Group, which I work in London. Few partners, mostly salaried doctors. And the 5th and 6th models are so-called integrated care partnerships, where you bring together general practice with community services, with hospital services, often with local government, into single organizations. The community provider partnerships are led mostly by general practice, and the hospital provider partnerships are led mostly by hospitals. And we've got a small but growing number of hospitals that are starting to buy up and run their own local general practices. All of these models coexist. There's no single model that stands out at the moment. Some people say, well, that's quite innovative and quite interesting. Other people say, well, it just looks messy. I think if we look at these models, then each of them has pros and cons. You might have a visceral reaction as to whether you like them or not, but actually there are advantages and disadvantages. And I just want to kind of stand back a little bit and look at some of those advantages and disadvantages. The most obvious advantage here is that we have a major workforce crisis in the UK. We're having major problems recruiting both doctors and nurses to work in the primary care sector. And we have a major crisis affecting us in so much as small practices are seriously at risk, particularly single-handed practices, and practices that have older GPs, and we have a growing proportion of GPs over the age of 55, are also at risk. And if you classify practices according to those two criteria, you can see a large number of practices in the top right-hand side of this graph, which are at major risk in terms of their sustainability. What we're finding is young professionals, particularly young doctors, want to work in larger organizations. They don't want to work in small organizations. They don't want partnerships. They don't want the responsibility of running a business. So they're much more likely to go and work in larger organizations, and therefore there might be an answer to the workforce crisis. The second potential argument for larger scale is that it encourages investments in building. This is the building that I worked in when I went into general practice in the late 1980s, a small converted terraced house, which I proudly put my brass name plaque outside of. This is the building that I work in now, an architect-designed building in East London, a health and well-being centre that brings together primary care services with community and hospital and social care services. It's an amazing building that makes patients feel different, and it makes the people who work in the building feel different as well. And what we're seeing with larger scale is a greater willingness to invest in innovative buildings like this. The third reason is that it allows efficiencies in back office functions, and some of the models that I've described to you have got shared human resource, staffing functions, shared finance, shared information technology, a lot of sharing of data and quality improvement activity as well. The next possible reason is an opportunity for individuals working in these centres to develop a range of different special interests. I've got a colleague within my practice who's got particular skills in dermatology, and we spend a lot of our time sending our patients with significant dermatological problems to her rather than referring them to the hospital. It also allows doctors to have the mixed portfolio career, which is very popular amongst younger doctors, perhaps becoming teachers or becoming researchers or becoming quality improvers or professional leaders. And finally, this larger scale allows practices to take on more of a population perspective, to think not just about the needs of the individual patients in front of them, but how can they improve the wider health of the community. So as a consequence of these cases, of these reasons for larger scale, a number of people say, well, it's just a given that we're going to get bigger and bigger in the scale of general practice. And there's very little debate about the disadvantages. So let's look at some of the disadvantages. The most obvious one is that in larger scale organizations, it's much more difficult to provide personal care. The modality group that I described to you based in Birmingham has got very good data now that it's providing better access and better clinical care, adherence to guidelines, than its previous practices used to do, but its patients aren't happy. They don't like this large anonymous organization. The second reason is that it's unclear what impact this dissatisfaction of patients with large-scale organizations might have on the trust which is so fundamental to us as GPs, the trust that builds between patients and doctors. The third problem is that the personal commitment from staff seems to be lost. We're seeing a growing number of younger doctors that work in an organization maybe for 6 months or a year or maybe 2 years and then move on. They don't have the same sense of commitment or the same sense of responsibility. It's more anonymous. It's easier for them to move on. We're seeing a reduced goodwill amongst doctors as well. And I think people forget how much goodwill is at the basis of the partnership model that we currently have in the UK. But most fundamentally, the Starfield argument for general practice, the argument that we as GPs use so much to make our case for general practice, may not be relevant if general practice operates at large scale. All of the arguments in favor of general practice, that general practice as a basis of a health system delivers better value are based on the small model of general practice? Will they still be viable arguments as practices get bigger? I don't think there's any right answer if you balance the pros and the cons of at-scale general practice. I do think that this shift is probably inevitable in the UK at least, but it doesn't mean it's irreversible. In the retail sector, we've seen small shops being replaced by large supermarkets and department stores, but now we're seeing a resurgence of small shops again, as people are saying that people want an experience that's more personal. The same could easily happen in general practice. The challenge, I think, is to preserve the strengths of general practice as we currently see it with the small model and be able to transfer them into larger organizations if that's what's going to happen. The second challenge that we see facing general practice is challenges to the medical model. And as I say, I want to address this reasonably quickly because of Gilbert's presentation and more presentations that we're going to see over the next couple of days. My hypothesis is that general practitioners need to play a key role in leading this process of demedicalization of healthcare. This is Louise. Louise is a patient of mine who went to see our practice nurse to get the results of some blood tests and was told that she had pre-diabetes. The practice nurse went to see one of our locums who prescribed metformin for her. Louise then came back to see me in a consultation, and she was really very angry. She said, "Dr. Marshall, have I got a disease or not? And do I need to take these silly tablets or not?" And my answer as a specialist in uncertainty, as we all are as GPs, is, well, maybe you've got a disease, but maybe not. And maybe you need to take those tablets, but maybe not. Louise had done a lot of reading around overdiagnosis and the risks, in particular, of pre-diabetes. So we had a conversation about the extent to which pre-diabetes was a real disease. We had a conversation about whether treating it with tablets or treating it with lifestyle was reasonable. We had a conversation about the risks of pre-diabetes turning into full-blown diabetes, much smaller risks than many people would accept. So I had this conversation with Louise, and it made me think yet again about this risk of overdiagnosis. We all know, as Gilbert says, that medicine's achieved an enormous amount in our health systems. As Cyril Chandler, one of my colleagues at UCL, said, medicine used to be simple, ineffective, and relatively safe. It's now complex, effective, and potentially dangerous. This is leading to a process of scrutiny of the medical model that's underpinned so much of what we've done in our health systems. This process of scrutiny is less radical, it's less shocking to us as GPs because we've always had our doubts about the medical model. That's why we've orientated ourselves around the biopsychosocial model. But the overdiagnosis movement provides us with a structure and a rationale to do something that we've been struggling to do for decades, which is basically share the uncertainty that's inherent in the medical model. The trouble is the medical model doesn't help us to share that uncertainty. The medical model produces what George Bush described as artificial certitude. We've managed to seduce the public, we've managed to seduce policymakers, we've even managed to seduce ourselves with the so-called benefits of medicalization. But there's a slow realization that it's not as effective as it used to be, that there are opportunity costs, that there's waste and damage caused by over-medicalization. This argument, of course, isn't a new one. Ivan Illich in the 1970s, in his wonderful book, Limits to Medicine, described how health is a capacity to deal with the human reality of death, pain, and sickness. The major threat to health in the world is modern medicine. I think all doctors should read this book, Limits to Medicine. It's not an easy read. In some places, it's quite a heavy read, but it's a really important one. Richard Smith, who used to be editor of the British Medical Journal, summarized the Illich argument rather beautifully when he said, "When I'm sick, I want to be cared for by doctors who every day doubt the value and wisdom of what they do." This critique is now being turned into something very practical, slowly but surely, in the United Kingdom. We're seeing a range of different movements, all of which are taking positive action to demedicalize the nature of our health systems. The British Medical Journal for the last decade has been running its Too Much Medicine campaign, started by an Australian journalist, Roy Moynihan, mostly talking about the risk of big pharma. But over the last 5 years or more, over 200 articles have been published critiquing the value of medicine. The Royal College of General Practitioners 3 years ago launched the Overdiagnosis Group, led by Margaret McCartney, who's going to be speaking to you tomorrow. This is a Google group, over 300 members, which is starting to have a significant impact on, for example, our National Institute for Clinical Excellence that produces guidelines, turning those guidelines into issues that are much more patient-centered. The Choosing Wisely campaign, which started in Canada and the United States, is now taking off at some pace in the United Kingdom, led by our medical royal colleges. 11 colleges have come together, and they're making specific recommendations to their members to do different things. So the Royal College of General Practitioners is encouraging us to rationalise our medicine, particularly for people who are in the last year of their life. It's encouraging us to do much more shared decision-making. And then in Scotland, we have the realistic medicine movement. The Scottish Chief Medical Officer, Catherine Calderwood, has introduced a really interesting initiative which has grabbed attention. 10 million tweets to the realistic medicine movement in the last year, in which she's brought together the concept of over-medicalisation with systems improvement and with personalised medicine. Add to these 4 initiatives in the UK the initiatives that are going on elsewhere in the world, like the Less is More initiative led by JAMA in the United States, and the wonderfully named Slow Medicine movement in Italy. It could only be Italy. And we can see something really exciting happening. This is maturing as an entity from a protest group at the impact of big pharma to something much more sophisticated, something around how we share uncertainty with patients, and increasingly something around a wider alternative model to the medical model, which I'll come on to in a few seconds. These are small changes, but it seems to me that it's likely that the overdiagnosis, over-medicalisation agenda is going to, at some stage soon, hit a tipping point, in the same way as the evidence-based medicine movement did in the mid-1990s. I don't think we can overstate the importance of this movement for general practice and how important general practice leadership is to take it forward. And the reason for that is we're all struggling with the same problem. We all essentially have unsustainable healthcare systems. This is the potential growth of gross domestic product that we spend on health in a range of different countries. And what it demonstrates is that over the next 20 or so years, the gross domestic product of Spain and the United States is going to almost certainly bankrupt their economy. We need to do something about that. And we are doing it in terms of systems improvement. We are doing it by redesigning our systems. But actually, if we fundamentally don't address the excessive cost and low outcomes of over-medicalisation, then we're not going to get anywhere. And the third and final change that I see happening in the United Kingdom, which I think is relevant to general practice, is a growing interest in the social determinants of health. And my hypothesis here is that general practitioners may have a greater impact on the health of their patients and their communities if they focus less on the medical and more on the social determinants of health. Let me remind you of a very simple fact. Only 30% of our health is determined by factors within the remit of medicine, things that we treat using the medical interventions that are at our disposal. 70% of our health is influenced primarily by social and environmental factors. General practitioners, of course, have long recognized this. That, again, is why we're interested in the biopsychosocial model. We have a unique understanding of how our patients interact with the environment within which they live. We built our identity around whole person medicine, and we differentiate ourselves from medical specialists and our medical specialist colleagues, who we disparagingly call partialists. We're operationalizing this at the moment by taking the psychosocial element of people's illness into account in a way that Balin described. But the problem here is that the emergence of guidelines, the emergence of specific disease-based metrics, of financial incentives, particularly in England, are forcing us back into the medical model. So though GPs want to function at the margins of the medical model, we're being forced back into it. The evidence from initiatives such as the Quality and Outcomes Framework, which is the massive incentive scheme introduced into general practice about 13 or 14 years ago, is interesting. A massive investment in order to improve the disease-based processes that we work on in general practice, which has demonstrated that as a consequence of this incentive, we are better at adhering to guidelines, but there's no improvement overall in the outcomes for patients. What you can see in this graph produced by Martin Rowland and his team from Cambridge is a progressive improvement in health over the last 10 or so years, which QoF introduced in 2004 has had almost no impact on. So the suggestion is that we need to move on from QoF in a way that they have done in Scotland and we're about to do in England. We need to revisit the whole person agenda and provide an opportunity to move from the disease-based pathogenic model to the wellness-based salutogenic model. So the question then is, what causes wellness? Harry Burns, the ex-chief medical officer in Scotland, described wellness in a really interesting way. He said a sense of wellness is dependent on the world being perceived to be comprehensible, manageable, and meaningful. He says it's this sense of purpose, this sense of meaning, this ability to flourish, to be in control of your life, that allows us to be healthy. So the world needs to be comprehensible and manageable. If it isn't, if we can't make sense of our life, then we lose control, we become alienated, and then we become ill. We've recognized, of course, social determinants in some of the work that we do, in addressing smoking and alcohol and diet and exercise. But these, of course, are just manifestations of the alienation that causes disease. They're not the primary cause of disease. There's growing evidence for this hypothesis from biology, bringing together sociology and biology. So social chaos, such as loss of jobs or homelessness, has an impact on stress hormones, which has an impact on brain development, particularly the hippocampus, which is the part of the brain responsible for allowing us to cope with stress. Stress leads to physical ill health. And it's this brain development, which is why a growing number of programs are targeting children at a young age in order to improve their longer-term health later in their life. In Scotland, again, they're starting a primary care collaborative looking at children to improve their lives, bringing together a range of different professionals. So it seems to be time to turn our rhetoric of whole person medicine into the reality of concrete action. What can we do differently in order to help our patients with the social determinants of their ill health? Those of you who've heard me speak before might have heard about Mohammed. Mohammed's one of my favorite patients. Or I guess when I was a younger GP, he would have been one of my heart-sick patients, actually. But now I'm older and wiser, I regard him as an intellectual challenge rather than the heart sink. So Mohammed's in his early 30s. He's from Iran originally. He's married with 2 children, and he lives where I practice in East London. He's obese, he's got a BMI of 35, and he's got type 2 diabetes. Diabetes which is proving almost impossible to control with conventional medical treatment. So I had a conversation with Mohammed about his diet, and I asked him, "Tell me what you eat, Mohammed. What's your food like?" He said, "Really nice food, Dr. Marsh. I eat lovely food." It turns out that he eats 2 meals a day in this fried chicken shop. Now, those of you who know East London will know there's a lot of fried chicken shops in East London. Indeed, the last statistic, there were 47 fried chicken shops per secondary school, per high school in my part of London. And Mohammed eats there for a very simple reason. He lives in an apartment, a 2-bed apartment with 4 beds, with 17 other people. They hotbed, they have a rota for the bed. And when he's not in that flat, which doesn't have any kitchen, so he can't cook vegetables, he goes down to the fried chicken shop where he has food that he enjoys, which is incredibly cheap, about €5 for 2 meals a day. And it's a place where he can get peace and quiet and just have a chat with his friends. So what do I do for Mohammed now? I still adjust his medication. I still do the medical stuff that we need to and must do as doctors, but I do far more than that. Over the last year, I've referred Mohammed to exercise at our local gym. I've referred him to a cooking class. I've referred him to a community legal clinic in which he can have a conversation and help to sort out his benefits. So I've done lots of social prescribing rather than medical prescribing, which slowly but surely is starting to have an impact on Mohammed's health and on his wider life. What I'm doing in my practice is really just at the margins of shifting from a medical model into a social model. One of our neighbouring practices is doing much more radical things. The Bromley by Bow Centre, based in Tower Hamlets in East London, was established in 1985 by a church minister in a similar deprived community to the one that I work in. The centre is built around a small park because environment's important, and it provides a range of services, including training and skills development for its patients, employment advice, family support, a nursery, a community cafe, workshops, an art studio, an incubator for small enterprises, which over the last decade has raised £6 million and employed over 300 people. And it also happens to have a GP practice as part of this centre as well. But it's not a normal GP practice. It's a GP's practice where the rhetoric of patient-practitioner partnership is really lived out to the full. The Bromley by Bow Centre is owned and run by the community. It's a social enterprise. The focus is on developing the self-confidence of the people, on their independence, their resilience, and developing their skills. It's the most positive place you might ever have seen. If you walk in the door, you could just feel the energy, the creativity, and the entrepreneurship there. It's constantly building on these assets, and rather than the assets that exist in the community, rather than talking about the deficits in the community. So the whole model is about medicine backing off. It's not as doctors as providers of health services, but doctors as navigators or facilitators, helping to create an enabling environment in which healing can take place. And the fact that these people are doctors rather than non-doctors is really important in terms of the impact and influence that they can have on their patients. It isn't an easy model to make work. It isn't spreading, but we are doing an evaluation of the Bromley by Bow Centre at the moment in order to understand what its core components are and what we can do to help it to spread more effectively. It seems to me that Bromley by Bow Centre doesn't represent just an adaptation of the medical model, the same as we've always done, just a bit less paternalistic or a bit more shared decision-making. It's a fundamental shift in how we think about health and well-being. Do we really want to go down this line? Do we want to redefine ourselves as GPs as social practitioners as much as medical practitioners? Some say they definitely don't. This isn't their comfort zone. It isn't what they were trained to do. It isn't where they want to be. But it seems to me the definition of a fool is someone who carries on doing things even though the evidence is that it's not making much difference. So we have a real challenge for us as GPs, and the social model seems to me to have good theory and a growing evidence base behind it, so it's worth exploring. The evidence base is growing. This study produced by colleagues in Glasgow, led by Stuart Mercer, is evaluating a complex social intervention called the Care Plus intervention, which contains a range of different social interventions, which already, using a cluster randomized controlled trial, is starting to demonstrate some significant changes in outcomes for patients. So in summary, general practice is changing, and it's changing probably faster than it's ever changed. Some of these changes seem to me to be really radical. I've described 3 changes which I'm seeing happening across the United Kingdom. First of all, a purposeful process of demedicalisation of health. Secondly, a related replacement of that medical model with a social determinants model. And thirdly, larger scale organisations which make these changes more possible. I'm looking forward to hearing what you think about these changes. What are you doing in your countries? Are you already practicing some of this social determinant approach, this demedicalisation approach? Do you think it's a good thing or a bad thing? Do you embrace or do you resist these changes? I've personally got no doubt that we as GPs need to preserve what we're good at. We need to carry on preserving the essence of general practice, the personal relationships, the therapeutic relationships that we have with our patients. But I also have no doubt that in order to be relevant to society in the future, we need to shift the model in a range of different ways. It seems to be all change for general practice, and it's time for us to take control of our future. Thanks very much for listening.